All right. So our next speaker is ready, and so we'll go ahead and get started, and I'll let Dr. Block introduce him.
Okay, I'm very pleased to introduce our next speaker, who's a cardio-oncologist at the Toronto General Hospital, the University Health Network. Dr. Thavandiranathan is the director of the Ted Rogers Program in Cardiotoxicity Prevention. It focuses on cardiac toxicity from systemic therapies, including cancer therapy. His research interests are identifying reliable cardiac imaging and circulating biomarkers for predicting heart failure in individuals receiving cancer therapy, to discover novel drivers for vascular disease in cancer survivors, and develop a risk prediction algorithm for patient-specific cardiovascular disease risk stratification. I heard him talk at the San Antonio Breast Cancer Symposium, and it was a truly wonderful talk, and I think you'll enjoy it.
Thank you very much. Let me share my slides. Great. Okay. Thank you so much, and thank you for the invitation to speak today, and thank you very much for your kind introduction. It was an absolute pleasure for me to speak at SABCS, and also an absolute pleasure to speak today at your conference. And I'm sure this is a bit of a change in pace and focus to the other topics that you're talking about. Hopefully I can make it relevant to your clinical practice. I have no relevant disclosures to this talk, and what I will discuss today is the spectrum of cardiovascular risk and cardiovascular disease in patients with breast cancer. I'll discuss some of the primary prevention and monitoring strategies with strengths and limitations. I'll discuss some of the optimal detection methods, and the recent ESC Cardio-Oncology Guidelines were published in August of 2022. It's a huge document, but it's freely available and can be helpful. Certain sections of it are very relevant to the breast cancer population. And I'll be highlighting some of this, and you can go back to it and pick up the guidelines if you have an interest in the area. Just starting off with some background, we understand that breast cancer and cardiovascular disease are significant cause of morbidity and mortality, but we also do understand that cardiovascular disease is about 10-fold more common in women than breast cancer. The 5-year survival of breast cancer is remarkable now. But if you look at age-adjusted mortality, still stroke and cardiovascular diseases such as coronary heart disease are much more important contributors to overall mortality. Now, specifically, however, in women with breast cancer, we do see a higher prevalence of cardiovascular disease. This is some work from our province, Ontario, Canada, which is the largest province in the country. We looked at about 72,000 women with breast cancer, and we looked at the cardiovascular disease that they developed. Although we traditionally think of heart failure in this population, ischemic heart disease, cerebrovascular disease, and arrhythmias were actually as common, if not more common. And we always ask the question, why is this the case? We know that there are shared risk factors for cancer and cardiovascular disease, meaning subclinical cardiovascular disease that manifests itself during therapy. The lifestyle changes may contribute to new cardiovascular risk factors, such as a decrease in physical activity. We know that inflammation contributes to both cancer and cardiovascular disease. We think primarily of cancer therapy, which can also be a contributor, We also find that our survivors don't perhaps get the same cardiovascular care as patients without cancer. And all of this likely contributes to the burden of cardiovascular disease. We know with breast cancer therapy that the treatments have evolved. It's really the anthracyclines and HER2 targeted therapy, particularly trastuzumab, that resulted in the growth of the field of cardio-oncology, where we have soon realized that it's much more than that. And I've listed some of the drugs that are currently used for breast cancer and some of the toxicities that we see. But the most common, most recent addition to our clinic has been those patients who are receiving immune checkpoint inhibitors who are developing myocarditis and other cardiovascular disease, such as accelerated atherosclerosis. The development of cardiovascular disease is not benign. So again, Ontario population-based data, about 37,000 women. We followed these women over time and looked at what happened, and you can see that in the older women, breast cancer is still the primary cause of death, but cardiovascular disease is the second most important cause of death. And in some populations, such as those with pre-existing cardiovascular disease, as you see on the right-hand side, cardiovascular disease is as an important cause for death. And by about 4 to 5 years, cardiovascular disease takes over as the primary cause of mortality in these patients. So today, I will focus primarily on cardiovascular disease that develops during cancer therapy, because that is probably what's relevant to the audience. We as cardiologists tend to see a lot of these patients who unfortunately develop heart failure and cardiovascular disease later on. On Friday, I saw a 25-year-old woman who just finished breast cancer therapy and was referred to me with the EF of 25%, who we are managing aggressively to try to help recover her cardiac function. So I'll focus on toxicity that happens during cancer therapy. So I'll start off with the most common reason for referral to our cardio-oncology program, which is left ventricular dysfunction and heart failure. How common is this? I think this is variable depending on the treatment that is being offered. This is, again, population-based data where we looked at the different treatments that were being used in Ontario. And we see that the risk, the yellow line versus the blue line, seem to be driven by patients' risk factors, those who have more than one heart failure risk factor, and that includes diabetes, hypertension, older age, above the age of 60, and also atrial fibrillation. These patients seem to have about twice the risk, regardless of the treatment that's being given. And in some treatment regimens, such as sequential anthracyclines and trastuzumab, the risk was pretty high. And this is not asymptomatic fall in ejection fraction. This was clinical heart failure. By 5 years, about 5 to 10% of patients developed a heart failure. What was striking with the data, however, is even in the non-anthracycline setting, so predominantly probably TCH, we saw that a significant proportion of patients were developing clinical heart failure. And this may be driven by some selection bias because our oncologists tend to use TCH in the higher cardiovascular risk patients, and perhaps that's what that higher risk represents. Now, we know that the development of heart dysfunction is associated with poor prognosis. If you look at the traditional therapy, this is a very nicely done study from Italy, which followed patients with aggressive imaging for up to 5 years, initially every 3 months and then subsequently every 6 months. What was interesting is that most of the cardiotoxicity, in fact, occurred 3 to 6 months after completion of anthracycline therapy. But unfortunately, the challenge was once left ventricular ejection fraction falls, despite contemporary heart failure therapy, majority of patients do not have complete recovery of left ventricular function. And when we follow these patients to see what happens, many of these patients developed major adverse cardiovascular events. And not simple. This is death, acute pulmonary edema, hospitalization, and life-threatening arrhythmia. So recovery of cardiac function, early detection and intervention seems to be important in preventing adverse events in our patient population. Similarly with trastuzumab, much of this data were in sequential therapy. You see that early on, patients who developed heart failure require readmissions to the hospital, lower than other forms of cardiomyopathy, but still earlier on there's some readmission. And this is some really nice work from our colleagues at Memorial Sloan Kettering. Anthony Yu looked at patients who developed cardiotoxicity during treatment, and he looked at what happened 7 years later compared to those who did not develop cardiotoxicity. And when you look at heart function, their heart function is lower. But I think what was more important to me is if you look at these women's cardiopulmonary fitness as measured by VO2 peak, it was significantly lower. And we have seen some really nice data from Boston that has shown that low VO2 in women with breast cancer or cancer in general is associated with poor prognosis. What about some of the newer agents? So we have much less real life data here, but if you look at the clinical trial data, the risk of cardiotoxicity seems to be low, about 3 to 7% risk of fall in LVEF with lapatinib, and a small fall in ejection fraction with other agents, with no excess cardiotoxicity with some of the other in some of the other trials. We also see drug antibody conjugates. This is a nice review by Dr. Susan Dent, which summarizes some of the key trials in the area and the risk of developing adverse cardiovascular events, and it ranges from about 2 to 5%. So hopefully I've shown that, we do see LV dysfunction and heart failure. When it occurs, it seems to be clinically relevant and associated with subsequent major adverse cardiovascular events that contribute or shorten our patient's lifespan. So how do we prevent the development of heart failure and left ventricular dysfunction? As cardiologists, we use neurohormonal blockade all the time. This is our go-to treatment when patients develop left ventricular dysfunction. So there has been an interest in looking at these for primary prevention, and I'm showing you the most recent study in this space that showed that overall, if you look at trastuzumab-treated patients, there was no benefit with these drugs, but perhaps in the higher risk patients receiving anthracyclines and trastuzumab, both beta blockers and ACE inhibitors seem to reduce the risk of developing cardiotoxicity. But if you look at the meta-analysis overall, there's a lot of heterogeneity in the published data. And if you use this in primary prevention, perhaps there's about a 4% reduction or prevention of reduction in LVEF. Whether this is clinically meaningful or not is unclear. I think where we need to go is large randomized controlled trials with clinically important outcomes such as heart failure, which we need collaboration with groups like yourself to be able to conduct such studies to see if these are actually clinically valuable prevention strategies. Where there's been a lot of also interest is in dexaroxane. This is an ion chelator, a drug that inhibits topoisomerase 2 beta, studied a lot more in the pediatric cancers. This was a meta-analysis of the breast cancer population. And you can see, when you look at clinical heart failure and cardiac events, there's a remarkable prevention benefit here. The only challenge currently is that this is FDA approved only for cardiotoxicity prevention in women with metastatic breast cancer who are receiving more than 300 milligrams per meter squared of doxorubicin. Therefore, in many of our early stage breast cancer patients, this is not indicated. My use in my clinical program today is when a patient is referred to us with breast cancer, and perhaps they have received the cancer for a pediatric malignancy, and the team feels that an anthracycline-based therapy is the best option for this patient, and they'll be reaching perhaps 400 or 500 milligrams per meter squared. That is the population in which I use this, and it does take a little bit of working with our pharmacy, but when used, I found it to be extremely effective. The other drug where there's been a lot of excitement is with statins. Statins are used commonly in cardiovascular disease. Lots of retrospective and population-based studies that have shown that if you use a statin intentionally, you may be able to reduce the risk of heart failure in these patients. So this was the first randomized control study that was published in August of last year, which looked at using statin. This was a predominantly breast cancer population. And they looked at MRI measured left ventricular ejection fraction. And this is probably the consequence of running a cardiology study in an oncology population during COVID, where patients are obviously focused on more important things, which is their cancer health. So there was a lot of loss to follow up with primary outcome missing in a lot of patients. So keeping that in mind, there was really no difference in left ventricular ejection fraction at the 2-year follow-up, which is their primary outcome. And also important to keep in mind, they enrolled all comers, not only patients at high risk for cardiotoxicity. There are 2 more trials that should be reporting this year, STOP-CA and SPARE-HF, which enrolled higher risk patients, and we'll see if those trials show prevention in patients at high risk. So I think the problem in these primary prevention trials is that we have enrolled patients at all degrees of risk. And we would expect that these drugs are probably beneficial in the higher risk patients, and we really don't have a good way of risk stratifying patients. A few years back, ASCO provided some guidelines here. They provided these recommendations for high-risk patients, higher anthracycline dose, trastuzumab with risk factors, lower combination of these therapies. And there are several studies that have shown that baseline heart function is also an important prognostic marker, with every 5% reduction in EF associated with significant symptomatic heart failure or cardiovascular death. So baseline heart function is important as well. But the challenge is, as clinicians, how do we incorporate these individual risk factors for the patient sitting in front of you, such as adjuvant online that you may be using when you're having discussions with your patients? So a few years back, we developed the breast cancer risk score called the B-risk score that uses a set of clinical factors to determine 5 and 10-year risk of developing major adverse cardiovascular events in patients with breast cancer. Unfortunately, this still requires external validation. We used about 100,000 women to assess this, but I think it needs to be assessed in also a different institution or different center and different setting. The ESC guidelines have recently published these, what they call pro forma. So these are for the different treatment regimens. So I've just shown you one example of HER2 targeted therapies. They have come up with a set of clinical factors, biomarkers, cancer related factors, and you could count these factors and add them up to determine the patient's risk of developing heart failure. And the patients are categorized into medium, high, and very high risk of heart failure. The one limitation of this is that this is an expert consensus-based document, and it does require external validation. But the ESC guidelines did use these pro formas as the foundation to determine or to suggest different therapies based on risk. So when I'm talking about risk in my future slides, it's based on these pro formas. So take-home points for primary prevention. We don't have any established primary prevention strategies. Beta blockers, ACE and ARBs, may be of value in the high and very high risk patients. Dexaroxane, I gave you an example where I would use it in the high and very high risk patients, and the ESC has provided a class 2A level of B evidence for this. The role of statins are unclear. 2 major trials will be reporting in the next 6 months. And I think where we really need to go is to look at primary prevention strategies that are based on patient-specific risk, which we struggle with doing, and we don't do very well. And I think especially patients' genomics need to be included as well. And we are working on trying to include genomics in risk prediction. Hopefully, we'll have some useful results in the next year or so. So now, if you can assess patients' risk and you can't prevent cardiotoxicity, how do you detect left ventricular dysfunction in a reliable manner? So the first question is, does surveillance matter? This is, again, work from Dr. Anthony Yu from Memorial Sloan Kettering, where he looked at patients with clinical heart failure and he matched them to controls, and he looked at surveillance strategies. And what he showed is that surveillance was pretty good in these patients who were receiving HER2 targeted therapy at baseline, but it dropped off during follow-up. But what he showed is that in patients who had heart failure, if you did perform surveillance, about 50% of the patients already had a reduction in ejection fraction to less than 55% during treatment. And what he suggested is that if we do surveillance and we do identify left ventricular dysfunction, perhaps we could have intervened to prevent clinical heart failure. Of course, that needs to be shown in the future. Also, population-based data in the US in trastuzumab-treated patients show that at baseline, the compliance with imaging seems to be pretty good, but this drops off pretty quickly. And we have also shown, I've shown you this figure before, that there's a risk imaging mismatch in the sense that although patients with risk factors seem to be at higher risk, when we looked at imaging at baseline, we saw that there was no association between patients' risk and the frequency of imaging, again, suggesting that we struggle with risk stratifying patients. So again, I think the problem here is a risk stratification. I think as we are expecting a bit too much from our oncologists to be able to perform imaging as frequently as it has been suggested in the guidelines. And that's because we have just blindly followed what's been done in many of our clinical trials. And I think we need to move towards understanding when imaging is appropriate, which patients benefit, and at what timing imaging may be helpful. And we do see that here. You can see in anthracycline-treated patients, as I've shown you, it's 3 to 6 months afterwards. So perhaps if you're doing imaging, it should be at baseline and at one follow-up at 3 to 6 months. In sequential therapy, when we followed patients, we see that most of the toxicity actually occurs at 3 and 6 months into trastuzumab therapy after anthracyclines. So why should we be doing imaging every 3 months? Should we focus on baseline 3 to 6 months and maybe at the completion of trastuzumab therapy? And I think this is where we need to go with our imaging and surveillance strategies to make it better for our patients who are not burdened by imaging and follow-up, and also for our oncologists to not be burdened by having to do imaging so frequently. And I think there are several ongoing trials and studies that are looking at altering the frequency of imaging, and hopefully that'll help us move this field forward. So if you've decided imaging is needed, what technique should you be using? We have looked at echocardiography techniques. In Canada, we still tend to use MUGA, and the reason for that is because many of our oncology centers have MUGA, and our colleagues have much more rapid access to them than echocardiography. But if you use echocardiography, we have shown that 3-dimensional measurements of heart function seem to be the best to detect cardiotoxicity when compared to an external reference standard, which was cardiac MRI. And that is because this seemed to have the lowest variability. Now, 3-dimensional ejection fraction is no longer a novel technique. What I mean by that is it's routinely measurable in most echocardiography laboratories, and it's available as standard in most vendors, which means your lab, if you talk to your cardiologist, that this should be readily available for it to be reported in your patients. There's, as I mentioned to you, although EF should be followed, when we have a fall in ejection fraction that many patients don't recover heart function, there's been also an interest in this marker called strain. So this is, again, something that can be measured almost on all vendors and can be routinely done in a lab, maybe take an extra few minutes in your laboratory to measure this. This is just a better measure of contractility than ejection fraction. And early studies have shown that a fall in strain seems to identify subsequent risk of cardiotoxicity. So we asked, so what? Is it just an additional marker, an additional burden for our oncologists? Should we look at this in an objective manner? So we performed this international randomized control trial, 28 centers, where we randomized patients to be followed using this more advanced method, global longitudinal strain, and our standard of care ejection fraction. And when there was a fall in strain only without an ejection fraction change, we treated these patients with cardiac medications. And in the standard of care arm, we treated when there's an EF fall. So as you can see, with using a more sensitive method, of course, more patients receive cardioprotective therapy than using our standard of care method. Our primary outcome was a change in ejection fraction, and you can see there's a change in both groups, and this primary outcome was negative. So this was a negative study. Now, our predetermined secondary outcome was cardiotoxicity as defined by a binary outcome, and we saw about an 8% reduction in cardiotoxicity in patients in the strain-based approach with a number needed to treat of 13. Now, unfortunately, we have followed these patients for 3 more years, and again, trouble with running this trial during the COVID period. We had about a 23% loss to follow-up. At 3-year outcome, again, we see that there's no statistically significant difference in ejection fraction. When we look at cardiotoxicity, it's about 4 to 5% lower in the GLS-guided arm, but this did not quite meet statistical significance. So essentially, this may reflect the fact that, of course, we had loss to follow-up, but also perhaps even in this study, we looked at all comers and not only the highest risk patients. And particularly in the higher risk patients, there may be value to using these more novel markers to identify early cardiac injury. When I talk about imaging, people always ask about biomarkers, and appropriately so. And are there any values to cardiac biomarkers? And the measure that's potentially useful is troponin, but much of this data, both for HER2-targeted therapies and anthracyclines, were in the older era where higher doses of anthracyclines were used. And what we saw is that in patients who are receiving high doses of doxorubicin, more than 240 milligrams per meter squared, which I find is highly uncommon if anthracyclines ever used in our breast cancer population, that there may be some value, but we currently do not do this on a routine basis. Is there any prevention strategies with the use of biomarkers? Yes, in the earlier era with higher dose anthracyclines, but in the more contemporary era, we have not seen any studies that have used biomarkers to intervene to prevent clinical heart failure. So prevention and detection, take-home points. So I've hopefully shown you imaging is important in detection of LV dysfunction or risk stratification. The ESC guidelines suggest if you're measuring EF, use 3D echo, and that strain may identify future cardiotoxicity risk. But I think we still struggle with identifying the patients who would benefit the most from careful surveillance. And we really need to rethink the frequency and timing of imaging, not to burden our patients and our clinicians. Also, blood biomarkers, there may be a value to using troponin in patients who are receiving high doxorubicin equivalent doses. So this is lifetime doses. And there may be a value in the high and very high risk patients who are receiving anthracyclines or HER2 targeted therapy to do baseline biomarkers and follow these patients. But the value of intervention at this point is unclear. Therefore, it's difficult to recommend this in routine clinical practice. So the ESC guidelines do provide some guidelines here with respect to risk stratifying patients into low, moderate, and high risk group, and the frequency of surveillance, ECG, echo, and troponin, both with HER2 targeted therapy and anthracyclines. You can have a look at it with more frequent surveillance during cancer therapy. Now, I can imagine this is overwhelming, but if I can leave one thing with you is that if it is challenging to follow patients, the two most important times are to do some form of cardiac function assessment, especially in the moderate and high risk patients, before and after completion of cancer therapy. Because I strongly believe with following patients carefully for up to 10 years in our cardio-oncology program, if a patient has heart dysfunction, vast majority of it occurs early after cancer therapy. And if you can pick that up and initiate cardioprotective therapy, I don't think we'll see this phenomenon of late onset heart failure. My feeling about late onset heart failure, it's those missed patients earlier on who then just progressively worsen and then come to us, our attention in cardiac clinic with clinical heart failure. So we may be able to deal with that with some form of follow-up imaging done post-cancer therapy. The next topic I want to talk about is QTc prolongation. And I think in our clinic, this has become relevant in the context of CDK4/6 inhibitors. Most of you are familiar with this literature. And the concern is that prolonged QT increases the risk of ventricular arrhythmias and sudden cardiac death. Provided the normal values for males and females, the thought is that if the QTc gets to more than 500 milliseconds, there's a higher risk for QTc, or if there's a prolongation by more than 25%, and this increases the risk of torsades and sudden death. But hopefully I can show you this image on the right-hand side, where you can see that with these drugs, although we worry about QTc prolongation, when you look at actual sudden cardiac death, which is what we worry about, it is not that frequent other than with arsenic therapy. So although we worry about it a lot, if you look at it carefully, it's unclear whether the QTc prolongation itself is really a risk factor for sudden cardiac death. There's also problems with the measurement of QT. So most of your machines that are available in your clinics, and I think it's important for you to check with your cardiology colleagues what formula is being used. The Bazette formula is used to calculate corrected QT, and there are multiple different formulas. And you may wonder, why do I care about this? And hopefully I can convince you that this is important. The formula that's suggested in the guidelines is to use the Fredericia formula, which seems to be more accurate in the oncology population. So if you look at the CTCAE, the suggestion is that if you have more than 501 milliseconds, you have grade 3 toxicity. And many of the labels and guidelines do not say which formula to use. And the different formulas could have different clinical impacts. And this was really nicely shown in the study from the UNC Cancer Hospital published late last year, which looked at QTc values in about 6,800 patients and with 20,000 ECGs. So they looked at 3 different formula, and you can see on this graph here, the Bazette is the distribution on the right-hand side. The Fredericia and the Framingham are the 2 that overlap here. And when they looked at grade 3 toxicity, they were able to show that the Bazette identifies a greater number of patients who have grade 3 toxicity. And they showed that on average, a median QTc is prolonged by about 30 milliseconds, and higher CTCAE grade in 41% of the patients if you use the Bazette formula. And if you switch and use the Fredericia formula, about 81% of patients who have grade 3 now have grade 2 cardiotoxicity. And there was pretty good concordance between the Framingham and the Fredericia formula. So of course, if you're following changes over time, it's okay, you're using the same formula. But if you're looking at it cross-sectionally, it's important that we would be overestimating the number of patients who have grade 3 toxicity if you use the standard formula or the spit out that you have from your ECG machine. And many times this is changeable, or we can remeasure the QTc. So it's important to look at this carefully to ensure that we are not inappropriately interrupting our cancer therapy. Also important to keep in mind, there are many other factors beyond therapy that prolong QTc, coexisting risk factors, other treatments such as antiemetics that are used in these patients, and of course, nausea, vomiting, dehydration, and prolongation and electrolyte abnormalities can contribute as well. So important to keep in mind to look for other factors beyond just the drug itself and manage all of that. So ESC guidelines suggest that we should be measuring QT using the Preventio formula. And keep in mind, when you look at an ECG quickly, many patients who are receiving cancer therapy has this U wave, and sometimes the QTc is over measured. And if you have a conduction abnormality, such as a left or right bundle branch block, you can use this thing called the JT interval to monitor QT as well. So the recommendation is that in patients who are receiving ribociclib, baseline 2 weeks and 4 weeks ECG, and if there's a change in the dose, that it should be repeated. And with other CDK4/6 inhibitors, if there's high risk scenario, that these patients should have ECG follow-up as well. So take-home points for QTc prolongation: CDK4/6 inhibitors are associated with QT prolongation. Determine which QT correction formula is being used at your center, and the Preventio formula is the formula that should be used. And QTc prolongation, remember, is not only driven by the drug that you're using, and the drug that you're using has major impact for cancer outcomes, which are perhaps the most important in these patients, and the risk of torsade remains low. I can't remember the last patient who's referred to me with QT prolongation in whom I've said you should stop the drug. We've always found a way to continue on with the medication that you have chosen best for the patient. The last topic I'll discuss in the last 10 minutes is myocarditis, which I'm starting to see a lot more in our patients with breast cancer. We're seeing a lot of this in the melanoma population and the renal population before, but now I'm starting to see this in the breast cancer population. We have no known prevention strategies, so I'll focus on detection strategies in these patients. So what we see is that the incidence of myocarditis, if you look at cohort studies, is still less than 2%. So it's uncommon. But if you look at the combination of all forms of cardiovascular disease, the one that I'm more worried about is the coronary artery disease. We are seeing tremendous progression of vascular disease in our patients who are receiving atherosclerosis. When we look at patient CTs, within a few months of starting immune checkpoint inhibitors, we see a remarkable progression of their atherosclerosis and the risk of developing cardiovascular events. So if you look at a recent meta-analysis and look at all forms of cardiovascular adverse events, about 3% with monotherapies and twice that with combination therapies. Why do we care about myocarditis? Although it is probably the least common immune-related adverse event you would see, when you look at case fatality, this seems to be associated with the highest risk of mortality from the WHO data. So how do we make the diagnosis of myocarditis? The recent guidelines suggest there are two approaches: a clinical approach and a pathological diagnosis. So if a patient is referred to me and I can't figure it out using a clinical diagnosis, I move on to a cardiac biopsy. A cardiac biopsy is not available in most centers. Centers that do heart transplant, we do biopsy in heart transplant patient every few months. So like our center, our cardiologists are comfortable doing a cardiac biopsy, and we need to show inflammatory infiltrates and loss of cardiomyocyte to make the diagnosis of myocarditis. The clinical diagnosis, however, is most commonly how the diagnosis is made. We need troponin elevation and one major criteria or two minor criteria, and we need to be able to rule out coronary artery disease. So here are the major and minor criteria. The major criteria requires cardiac MRI, diagnostic for acute myocarditis, and most centers can do this quite well. We need to look for the Louise criteria, which I'll briefly mention. And the minor criteria are the clinical syndrome, so chest pain, shortness of breath, orthopnea, ventricular arrhythmia, so conduction abnormalities, a fall in ejection fraction. The most commonly associated immune-related adverse events, which is myositis, the 3 M's, myopathy or myasthenia gravis, these seem to be most commonly associated with myocarditis. And a cardiac MRI, which is not slam dunk for myocarditis, but does have some partial criteria which could be used as well. Now, how do we make the diagnosis clinically? Unfortunately, majority of the patients present from asymptomatically. So this is based on data from our international registry of ICI myocarditis. This is hosted by Dr. Tom Nealon from the MGH, where we have about 250 patients now in the registry, and we looked at what are their most common presenting symptoms. This is dyspnea and fatigue, so really very non-specific symptoms. And these patients have usually a physical exam that from a cardiac perspective that's normal. The timing seems to be important. So majority of the myocarditis seem to occur within the first 6 months. In fact, I would say majority occurs within the first 3 treatment cycles with the immune checkpoint inhibitors. So this is perhaps a time point when you're following these patients. That's important to be vigilant when patients are presenting with non-specific symptoms, because this may be the sign of myocarditis. The other most important marker is troponin elevation. And again, from our registry, we're able to show that almost all patients had an elevated troponin, but it's important to keep in mind that we should be using high sensitivity troponin I. So there are multiple different troponin measures that are available. There's troponin I and troponin T. Troponin I is the method that should be used if available. It's more sensitive. The other measure that seems to be helpful is BNP. So BNP or NT-proBNP, which is elevated in also 2/3 of the patients. So I tend to use both troponin I and BNP to be comfortable with the diagnosis. So if you're looking for myocarditis, consider troponin I and adding a BNP for the diagnosis as well. The ECG also seems to be helpful. We find in the registry that more than 2/3 of patients will have an ECG abnormality. And this includes PR, QRS, and QT prolongation. And interestingly, about 1 in 4 patients will actually have more advanced heart block, 2nd or 3rd degree heart blocks. And I think these patients should be managed in a cardiology service. So we tend at our center, Princess Margaret Cancer Centers across the street, and many of the patients are managed there. When we see a change in their ECG or a change in their heart function, then we take them over and we bring them to a cardiac site across the street, and we care for these patients in our cardiac intensive care unit. The one thing that's different from what I've talked about with the traditional cancer therapies is that we see that about a half of patients who present with pretty clear myocarditis with a high troponin in the thousands tend to even have completely normal left ventricular ejection fraction. So this emphasizes the point that if you're considering myocarditis and you get an echocardiogram and the function is normal, that is not sufficient to rule out myocarditis. So can other markers of contractility be helpful? Again, strain seems to be useful here. This is again data from the registry. If you happen to have a baseline measurement at the time of myocarditis, the strain seems to be lower. But if you don't have a baseline measurement and your patient has normal ejection fraction, compared to a control cohort, these patients again seem to have reduced ejection fraction. So when our laboratory does an assessment for myocarditis and they say the ejection fraction is normal, then my next question is, what is their strain? If the strain is normal as well, then likely there's no significant myocardial injury. But if the strain is normal, then I remain suspicious that this patient truly does have myocarditis. And finally, as I mentioned, cardiac MRI is the gold standard imaging method. And we use this Lake Louise criteria. Most centers who run cardiac MRI programs will be able to do this for you. And we have 2 main criteria and a supportive criteria. The MRI main criteria is we need to show myocardial edema. So that suggests that there is some form of injury that's going on to the heart. And we need to be able to show non-ischemic myocardial injury. And that is shown by these other methods. The reason this has come up is we're starting to see that when you activate T cells, the T cells tend to infiltrate the myocardium and not always cause myocarditis. But the inflammation causes edema, and we may be able to pick that up with cardiac MRI. And that is not a marker of myocarditis. That just is T cell infiltration to the myocardium. But we need to see that T cell infiltration is actually causing myocardial necrosis. And that's why we are looking for actually injury also by MRI. And that's what the troponin shows as well. There are some supportive criteria, which is pericarditis and systolic dysfunction that could help with the diagnosis. And when your oncologist, when your cardiology team is doing this, ask them whether they're using quantitative tissue characterization techniques as opposed to qualitative methods which were being used in the past, and the quantitative methods seem to be more useful for the diagnosis. So take-home points for myocarditis: troponin and BNP seem to be key biomarkers for the diagnosis. Having a baseline measurement is helpful. ECG is helpful, especially if you have baseline measurement. LVEF is not a reliable marker, as I've shown you, and strain may help identify myocardial injury, especially if EF is normal. Cardiac MRI is the reference standard imaging method and can still miss disease. And if your clinical suspicion remains high, consider a cardiac biopsy if available. Here are some surveillance strategies that has been suggested in the ESC guidelines. So high-risk patients are those who are receiving dual ICI therapy or have pre-existing cardiovascular disease. The suggestion is to do baseline assessment with echo and biomarkers and repeat it once at 6 and 12 months. And it is suggested, if you have the availability, that there may be screening that could be considered with every 2 cycles with measuring an ECG and troponin. But this means that you should have a good relationship with your cardiologist, because you want to be able to, when you identify a troponin, so what is the implication of that? So you want a cardiologist who works closely with you to help with that. It is not uncommon for me to get a call over the weekend or a text asking, what should we do with this? And we have a discussion with our oncologist. So you need to have a good relationship if you're going to institute such a screening strategy. That's all I had. Hopefully it provided some information that will be helpful for your clinical care. Thank you very much, and I'm happy to answer any questions.
Do we have any questions? I had a patient who started treatment with TDM1 and tucatinib on study, and after 1 cycle, and she was perfectly healthy, had baseline normal heart study. She developed a marked reduction in her EF. I want to say it was 30%. And of course, she came off the study right away, and we tried some other treatment and it didn't work too well. And so we ended up, her heart function went back to normal. We ended up putting her back on TDM1 off of study. And she's probably been on 1.5 years now and has never had any problem. So I guess I'm not clear on what some people might call a flash cardiomyopathy, the mechanism, and the fact that she has actually done so well since then. But anyway, do you have any comment on how often this happens? Or
no, thank you, and that's an interesting and important question. And one thing that I've learned over the past 5 years of following these patients is that our risk prediction tools are pretty crude, and we probably don't understand who's at higher risk. And as I mentioned to you at the beginning, I've had a woman like this, again, this is HER2 targeted therapy, but 25-year-old with an EF of 30% after 2 cycles. What I've done is I've brought these patients back, and I've actually included our geneticist. And when this happens and we started looking at their genetics, we're starting to see that many of these patients who respond like this have a genetic cardiomyopathy that was never known. So they have a titin mutation, for example, or a mutation in one of the genes. And when you dig in a little bit further, you find, oh yeah, my grandmother had a cardiomyopathy. So it is that population that have a genetic predisposition that we are starting to see that develop this flash cardiotoxicity. But even in that genetic population, we find that if you have them on a beta blocker and ACE inhibitor, we are able to get them through cancer therapy. I must say it's very uncommon for me to ever say stop cancer therapy. I can imagine in the past 12 years, there's one patient in whom we had an EF of 35% who have said, you may have to hold off after 3 to 4 months of initiating heart failure therapy. My approach is continue on with your therapy. Let me add medications that improves heart function. And almost always I can get patients through their cancer therapy. So I think to answer your question, this may be a missed cardiomyopathy. There may be a genetic cardiomyopathy. So I think it's worthwhile getting your cardiology, the genetics team involved. And it's not uncommon for patients to be on optimal heart failure therapy and to be able to complete the therapy, the very therapy that caused initial cardiomyopathy and heart failure.
do we have any other questions? Thank you very much.
Thank you.
Well, seeing none, thank you so much.
Thank you. Thank you.
All right, everyone. So it's now time for our break. I know we're a little ahead of schedule.